Thank you, Carmela. Good morning, everyone. It's a pleasure and an honor to be here presenting especially some part of the results of the LUNS study group, especially working on behalf of their group. This is a collaborative study that has been part of the ILSI efforts in Latin America, and the name of the study is Estudio Latinoamericano de Nutrición y Salud, or in English, the LUNS, or the food intake and physical activity patterns of Latin America population. We will present some of the methodology and the parts of the results. This is our presentation of interest disclosures. LUNS is originally supported by a scientific grant, or was supported by a scientific grant from Coca-Cola, and runs from all these different institutes, and publishing and communication is supported by ILSI Latin America and regional Latin American ILSI branches and a grant by Ferrero, but we do not allow any participation of the funders in all the papers and results of these views. Latin America, as you know, has one of the worst situations in nutritional status, and especially some of the projections that we had in the beginning of the years 2000 showed that probably would have at least 25 to 30% of population in overweight situation. But now we've seen that the projections that we had at this time for 2030 showing that Latin America and the Caribbean will show approximately 200 million of inhabitants with obesity were already established in the year probably 2020. So this situation will be very difficult to tackle, and some of the activities that we have to work on that is based on the traditional model of Gordon and Larson, showing that obesity must be evaluated in all these possible risk factors, especially their influence on behaviors and which would be the health outcomes. We will belong to the tradition of using some indicators on behaviors like eating, sedentary behavior, and especially physical activity. This could be important for the energy balance and all the health outcomes that we will see. We will see that there are lack of many studies in Latin America that combine nutrition and physical activity together, especially in representative samples. Up to now, there is no Latin American study using a central standard methodology across a group of participation countries. There are many studies in Latin America in different countries, some of them with huge populations and some of them with representative samples, but all of them uses some different methodologies. Some of them use only physical activity based on self-report, and some of them are using different methodologies for nutritional assessment. So, based on that, the LUNS has the aim to provide up-to-date, reliable, and comparable data of dietary intake, physical activity, and association with the anthropometric profile of urban population of 8 Latin American countries, representing almost 40% of the population of the Americas, by region, cultural background, socioeconomic status, age, and gender, and especially putting together all the possible risk factors to evaluate the situation in our countries. This is the situation that we are working in LUNS. We have 8 countries with 8 PIs and their respective teams. We have 4 international advisors. We have 2 project managers, and all the projects were evaluated by central committees and international committees and central IRBs. We have evaluated more than 9,000 people in a representative sample of urban household population of each country by geographical location, gender, age, and socioeconomic status, and all the survey was weighted for each of the economic situation in each country. We divided from teenagers to adults, to senior adults, and socioeconomic level were divided in 3 levels for each country based on the regional evaluation of socioeconomic level, and so we had to standardize the idea of putting together for all the country. This is the first paper that was published on that, the rationale and study design of LUNS. It was published 2 years ago, so based on all this situation, we are trying to have this idea. The variables that we were evaluating were intake based on 24 hours dietary recall for everyone. So we have more than 19,000 people evaluated. And we complemented by a beverage intake questionnaire, especially for food and liquid food, and especially the expenditure was evaluated in two situations, one by self-report by the International Physical Activity Questionnaire and by accelerometry that we'll explain later. This is where the outcomes for anthropometry. This is the dietary assessments tools that we were using. We used the 24 hours for everyone with the USDA multiple step for evaluation for each interviewer, and this is where the photograph books for evaluation of our food. This is the sheet for dietary assessment for beverage intake, and this is the paper that were published on the food standardization. So we had a methodology that was based on comparing each one of the foods and preparations in Latin America, trying to compare with national data bank, and especially after that to use one only international data bank that will be from the University of Minnesota, the MDS, and these were the matching for all the foods. Based on that, we had more than 4,700 of total food data standardized in all the countries, and all the countries had to have an agreement with the evaluation of the data bank more than 80%. After that, we had to evaluate the underreporters and the overreporters, so we had to exclude all these reporters, and it was the first publication that we have on that, and the second one will be published very soon. So all the data were evaluated only for the plausible people who were evaluating this data. Physical activity was validated by self-report by the IPAC. It was validated by a modification of the international version of the IPAC for the Mexican Spanish version, adapted for the countries of Alliance, and even for Portuguese countries, for Portuguese and Spanish. We had total vigorous, moderate sedentary times, transport and leisure times for all the minutes per week, and differentiation by week and weekend. Objective physical activity measurement were done by accelerometry. We had 40% of the sample. This is the biggest sample that we have for accelerometry done at the same time in the world. So we could use accelerometry for 7 days in more than 5,000 people in the same methodology at the same time. We have learned a lot with all this situation, trying to establish one only methodology for all these countries in South America. This is a novelty for us. This is not something difficult for Europe and other countries, but for South America it's very difficult. Establishing and planning the conduct of a multi-center research, selection of sites and team, evaluating data quality, and especially the dissemination of the findings. We have learned a lot. I will not showing all these issues for you, but we have published this in a recent paper that was published last week, or only last week, the issues in learning that we have developed from the Latin American study. So this is our last paper that appeared very soon. The publications that we had in this study were based, especially for all countries, in the primary publications that were based on the international database. And the initial papers were descriptive articles, especially the highlights from food, dietary intake, physical activity, and associated factors. The secondary publications were based on, for all the data countries, for the secondary approach. And now each country is doing their own research, so all the data that we had in the international data bank, they are being replicated for each country, so we have a dissemination of all the data that we have for the international data bank for each one of the country in weighted and especially representative survey for each one of these countries. The support for ILSI is a very important consideration for us, especially with the idea of using the ILSI Latin America and regional branch support. Based on that, we have some results that could be seen because we presented 19 abstracts of the lungs in the IOMS, 2 full workshops, and we have many regional presentations in each one of the countries, and some of them that were not part of a lunch like the US, and many operational workshops with different organizations, with ILSI Latin American branch, local health and education authorities. And now we are using the support of these groups for publishing in lunch and regional papers, and especially for support for statistical analysis, translation, and one of the most important costs that we have for these papers, that is certification and publishing in this region, and especially in impact factors, not very easy for our countries to publish methodology. We were very envy of the Europe situation, showing the facility that they have to publish reviews. The LUN's applications and future directions will be influencing science-based information on public health, especially because we will have new data that will be based on chronic disease prevention programs, fortification programs, drivers of food choice, diet diversity interventions, and many more. We have some possible cooperative participation with other countries in the region, and especially evaluating some different environmental questions like sustainability, biological versus cultural preferences, comparative data with other data banks, and especially this is a huge opportunity for the one ILSI because we are having the first regional LLA integration of branches in diet composition, recipes, potential future open data, regional workshops, and political influence. This is our group. This is some people when we were discussing the situation with health ministers in Central America, and this is part of our group. Georgina will continue with some of the results that are very, very new.
Good morning. Now it's my pleasure to present to you some of our results. As Mauro said, we have a total of 9,218 participants, and this is the distribution among countries. Argentina and Brazil has the largest sample size, and Costa Rica and Ecuador the smallest. We have almost equal percentage of men and women with an age average of 37 years for female and 34.5 for men. Most participants were younger adults with lower level of education and with a socioeconomic level either medium or low, since it is nationally representative of all the 8 countries. Nutritional status is usually assessed as body mass index. As you know, above 25 is considered as overweight, and above 30 is considered as obesity. As you can see in this graphic, the total for a lung sample is 26.8, so it's above the cutoff for overweight. Chile and Costa Rica has the highest BMI, and Colombia has the lowest. And for all countries, women have higher BMI than men. Something important here is that we take into account both classifications of weight and obesity. We observe a 60% of excess weight in our population. And this prevalence of excess weight for lungs, as I said, is 60%. That is higher in all the countries, being Colombia with the lowest. And as we saw in the last slide, Chile is the one with a higher percentage of excess weight. For most countries, women have a higher prevalence of excess weight, except for Argentina and Chile, which is on the contrary. We also can see country-to-country variation that may be pointed out as we may found some risk factors or protective factors that differ among the countries, and it's the aim of LUNS to identify them to later be treated as target of intervention. This is the mean energy intake by countries. For France, we had almost 2,000 calories per day. And the highest will be Ecuador and the lowest will be Chile. As Dr. Fisberg said, we have also been analyzing the problems of energy intake misreporting. We found a higher energy intake among men than women in all countries, and this is also significantly different among sex. The source of the energy intake, it will be the group of grains, pasta, and bread. And there's something very interesting, since we find that in the northern countries, the main source of energy coming from this group is rice in Ecuador, Costa Rica, and Colombia. But in southern countries, it's bread. Brazil, Chile, and Argentina. If we some grains, meats, nut processes, and eggs and oils, it will account for almost 50% of energy intake. And on the other hand, other products like fruits, vegetables, legumes, beans does not account for neither 20% of energy intake. And this will mean that we are eating less sources of fiber and micronutrients. As we can see in this next slide, the main intake of fruits and vegetables for one sample was around 200 grams per day, being Ecuador with the highest and Colombia with the lowest. This intake of fruit and vegetables is not shown here, but increased with age. Even so, the people over 50 years old, 70% of them do not reach the recommendation in both of the interview. Only 4% of the sample reached the recommendation for both days. The distribution of energy intake among the day may vary among the countries, being lunch the main meal in all the countries, except for Argentina, where dinner is also very important. We found also difference in breakfast and snacks. For example, here in Argentina, snacks only accounts for a very small percentage of energy intake. And Venezuela is higher. And regarding micronutrients deficiency, there's something very important that we found. It was the deficiency of vitamin D and calcium among a very important proportion of our population, principally in adolescents. Female adolescents from Costa Rica and Brazil and Chile, we found almost 100% of deficiency in vitamin D and calcium. Iron has a low prevalence of deficiency, and we found a mild deficiency from vitamin C and vitamin A. We also did an analysis of dietary quality. We established two patterns: quality, what we call healthy pattern, and is related to a high consumption of healthy items, and the unhealthy pattern that is related to low consumption of unhealthy patterns. So if you see a high score in an unhealthy pattern, it means that this group is consuming a relatively low quantity of this. And as you can see, Argentina is the one with the lowest dietary quality, and Peru is the one with the highest, and it will be coming up as the healthy pattern does it, and we didn't see that on the unhealthy pattern. We found no difference among sex or age groups, neither nutritional status, and Regarding socioeconomic status is something very interesting since Argentina, which were the ones that showed the lowest score. As you can see here, the people with the lower income will report a lower dietary score compared with the high income. But this is not the case of Peru, where even in the low income, they can reach a higher dietary score. Regarding self-reporting activity that we assessed by the IPAC questionnaire, we found that men in the female adolescents reported the higher percentage of activity people, and the lowest we found in female adolescents and older women. In general, we found that less than 50% of the population were classified as physically active. And when we assess physical activity by the accelerometer, we divided the population among those in the lower, what we call moderate vigorous physical activity limits. And for female adolescents, we have the higher group here, and for women, we find it in the group of from 35 to 49 years old. So, in summary, we find a very important percentage of overweight and obesity, being Colombia with the highest problem, and the lower in Chile with the higher, and Colombia with the lower. The main intake of energy will vary among countries, sex, and age group. We find a low consumption of fruits and vegetables, a higher deficiency of calcium and vitamin D, low quality diet that seems not to be related to social income, nutritional status, age, or gender, and a high percentage of insufficient activity. So we still have a lot of work to do. As you can imagine, we have 24-hour recall for more than 9,000 people. So our database is huge, and we still are working on that, and we have some audit approaches that we need to continue working on. We are working on, as we said in this report, in added sugar, other sources of nutrients such as micronutrients, diet scores, food patterns, and we want to analyze if these food patterns may differ among countries, so we could find food patterns for that can explain food intake for the whole region, breakfast consumption, snacks consumptions, and on the other side we can see all the associations that we can make with social issues like income, violence, gender and diet associations, behavior, sleep time, and we have a lot of work still to do. This is our scientific committee. Dr. Atilio from Chile, Dr. Irina Kowalski from Argentina, Yadira Cortez from Colombia, Marta Yepes from Ecuador, Rosina Pareja from Peru, and Marianela Herrera from Venezuela. We also have our project managers, our external advisors in accelerometry, physical activity, and statistical analysis, and NDSR for food intake analysis. We also want to acknowledge our institutes and universities that have been supporting us, and our founder. If you have any questions, Dr. Mauro, I will be gladly to answer them.
Stephanie Atkinson from McMaster University in Canada. Did you do any blood work at all to do biomarkers?
Unfortunately, no. We don't have biomarkers.
Yeah. Well, I would just be careful about saying you have vitamin D deficiency, because in our survey in Canada, and We didn't have one for 35 years either, but finally in the 2000s we had a new health and nutrition survey. We also found 85% of the population had inadequate intakes of vitamin D compared to the estimated average requirement. But that is not equal to deficiency, because we did biomarker 25-hydroxy-D status, and 10% of the population was deficient. And you have much more sun in South America than we have in Canada. So my guess is that you probably don't have rampant vitamin D deficiency.
Yeah, I should say inadequate intake.
Yeah.
You're right.
And did you capture supplement use? I don't know how prevalent that is, but...
Yes, we have some data about supplements. We were very specific in Costa Rica, but it was taken into account into the 24-hour recall.
Yeah. Because in Canada, anyway, it's a big part of the vitamin D intake.
We do not have in this survey the levels of vitamin D, but we have some regional evaluation of vitamin D, especially in Brazil. We have a high tropical situation in our city, especially from the middle of the country to the north. We have a tropical situation, but we have more than 75% of the population from the teenagers and older with vitamin deficiency by biomarkers. So it's a situation that we have to see what's happening, because we are not using blockers and protectors for all the population at all. So we have a situation that we have nutritional deficiency, and also we have biomarkers showing that we have an epidemiological situation to see.
Yeah. Okay, thank you.
Allison Yates, retired from USDA. Realizing you have 8 countries, I would assume, and I don't remember exactly which countries have their own reference values for adequacy of intakes. Did you develop one, or did you use the codex numbers, or what did you use to establish the inadequate intakes in the vitamins?
We are using usually the international US and Canada data, and we don't have many recommendations for each countries. We use international, the Academy of Science and all the things, so we are using the international parameters of that. They are not so different when we are evaluating food by food in our regional data bank. But we have to remember that the Latin America data bank is very, very small. So we don't have comparison for that. So we have to use international data bank for that.
Well, and so
recommendations also.
So the recommendations
Yes.
are the U.S. Canadian DRIs. It's what you use.
Yeah.
And then my second question deals with establishing healthy diet. You used that as a evaluation. What did you consider as a healthy diet? Was it a already determined pattern or dietary pattern that you use?
It's not a healthy diet by itself, but we followed paper of Imamura that he worked with 187 countries, and it's a pattern built up on the consumption of healthy foods, and the other one with the low consumption of unhealthy foods. So it's not like a recommendation, just evaluation, the quantity of the items that have been eaten.
So if there were high intakes of fruits and vegetables, that was considered healthy. If there were low intakes of sugar, that would be healthy. It was more of a qualitative evaluation. I noticed you were thinking of trying to develop healthy eating indexes as one of the next steps. So I guess you could kind of quantify it so you could do that more globally, maybe. Thank you.
And Catherine Ena from Institut Polytechnique La Salle in France. Congratulations for your study, because I think it's not easy to get all the countries standardized in terms of dietary assessment. I have one question about intake of sugar-sweetened beverages. if you look specifically into this intake, and if you look at which kind of food group could explain the excess of overweight and obesity, if you have already looked what food groups contribute the most to energy intake, because the energy intake that we've seen were quite low and may not maybe completely explain the excess which we have seen. But of course, it's very great that you have accelerometers for physical activity to look at both.
Just for be sure, we are publishing this next month.
Okay.
We received the news that our paper on energy will be approved, and the next one will be on sugar and added sugar. So, and we have some data that are very interesting, because we have very strong difference from Argentina to other countries. Argentina is showing a high intake of sugar. We have seen that the intake of sugar comes from some of the beverages that they have. They're natural beverages, not processed beverages. And so we have to understand the habit of especially using teas and infusions and beverages all the day, because they are using undipped sugar and water, sometimes not very easy to evaluate how much they are using, because they do refuel all the time. And so it's a typical habit of that. And in some of the countries, they have some added sugar from all natural preparations, from cakes and bakes and breads that they are using inside their homes, and not from other processed foods. So I think we will have some results based on the low intake of energy, but high intake of some density food.
Thank you. Thank you.
Hi, Jessica Campbell, General Mills. I echo the thought there on the congratulations of such a rich database and completing the study. It's very exciting to see this. One question, actually I have two questions. If I was tracking along correctly, I think I noted that Chile had one of the highest or higher BMIs while Colombia was lower. And then when I was watching your energy intake, I thought, aha, it's going to be on the energy side, right? We first start there, but I think I noted, let's see, Chile was lowest lower kilocalorie, and then higher for Colombia. And then I was thinking, okay, it's sitting in the energy expenditure, but it looks like right now you just have it analyzed for across the study, right? So in your manuscript that's coming up, will you also be looking at the energy expenditure part with the energy intake? Okay, great. So maybe it's a little teaser, but could you maybe postulate a little bit what we might see coming out in that publication? And my second question is a little bit different. Just curious to know about dairy intakes. Are you looking at those? And then are there differences in the types of dairy intake, whether it be fluid milk or yogurts or cheeses? So, thanks.
Regarding your first question, I think it's not so easy just to look at it as energy intake and energy expenditure. As we said, we also are analyzing misreporting, and we have not made yet any correlations with nutritional status and food groups or energy intake. But it's very interesting what you have pointed out. We are analyzing food groups specifically for dairy products in Costa Rica, and we will do it with other countries.
One of the issues that we have, especially for physical activities, is that our low population, our low-income population, they do have to walk a lot for getting their jobs or to have going back and for home, and they have a lot of time that they have to walk on, they have to spend doing this thing. But when we compare physical activity objectively, we see some results that are not very easy to understand. So I think we have to put together all the data that we have from IPAC, accelerometry, intake, with misreporters, and all the things together to understand why we have some strong difference, especially in Colombia, where they have the higher level of physical activity, and Chile with the lower physical activity and low consume of energy, but also very, very high consume physical situation, especially in nutritional status. But this is something that we have seen in other surveys, and I think probably in the next papers we will try to explain some of the conflicts that we have.
Congratulations. Manuel Baldeón from Universidad de Tecnología Quinoxial. Just a comment regarding this last point. Now we have to take into consideration the role of microbiota in the assimilation of energy and the way that we expend that. So just considering the activity and the intake won't explain the metabolism, the internal metabolism, and that's probably one of the things that you are seeing. Now, I had two questions. One is that one important thing is that this was a cross-sectional study. And to be meaningful, I think it will be important to have another one, an ELANS too. And the question is, if you're planning to do that, and what other variables are you, if you're planning to add to this work? And my second question is regarding when did we have the diagnosis and what are the proposals to do interventions? In our countries, I am from Ecuador, and we had for decades diagnosis and unfortunately none of interventions. And so I think it's very important for all of us in the academics and industry and government to really go farther than the diagnosis and do interventions studies so that we can evaluate what the measures that we are taking and how the nutrition is being improved or not.
I can answer the first question. We'll always also like to make a second part of ELANS to make a follow-up. And in a dream world, we would like to have some biochemistry indicators and to measure microbiota. But until now, we are not planning to do that. So.
As for intervention, I think this is very interesting because we have a lot of diagnoses, but for intervention, we are using some of this data to discuss with government and to discuss with some of the results that we have, especially on possible recommendations and the new regulatory situation that we have in Latin America, because we have very different approaches to that, especially some very radical, trying to have many different symbols and different nutritional panels. And so we are trying to discuss that our intake is different from one place to another, and especially the consume of salt, fat, sugar is based on our home cooking, especially in our schools and natural preparations, and not in different products that were they have a different political approach. So we have to combine this data with the political discourse in order to try to modify some political interventions that we have. As for prevention of obesity, this is something that all the countries are spending a lot in their public health systems, and it's not working like it is in other parts of the world, especially in the US and Europe also. So we were discussing with all our partners in Europe and the US how we can do some political interventions and trying to put together one regional situation to South America and Latin America, because I think we have the same problems. Even if we have different results, I think we can have some approaches that could be learned from one country to the other.